Right. Okay, guys, I hope that you're with me and you're back on your screens. I'm trying to save time so that you maximize your benefit with your time with me. Uh, I have been told that there have been several hundred people trying to get in. Unfortunately, I can only apologize that I have not been able to accommodate them. There have been around 600 people who have been trying to get into this course. My apology, and I promise that I will be uh, getting in touch with them very soon. I had my limitations. This is purely being done on voluntary basis. I'm very happy to contribute in your development, your training, and your learning. But for all these things, you need resources. I had limited resources and I'm doing my best. So
Appreciate it,
I,
sir.
sorry,
Appreciate it, sir.
thank you. So I will be repeating the whole session very soon. And this course actually keeps getting better because I'm constantly working on this course for last 3 years. And right, okay. So Nawal, we are ready. Are we ready, Nawal? Okay, so first question is a very easy question. Right, okay, guys, please tell me what is the name of this clinical sign? What is your main differential diagnosis? What blood test would you need in order to confirm the diagnosis and what could they show? Right, what is this clinical sign? So this is Kalonikia. What is your main differential diagnosis? What is the diagnosis of iron deficiency anemia? Sadia, you can't see. Faisal, is video okay?
Yes, sir. Video is okay, sir.
Okay. Right. So, guys, this is Kalonikia. This is iron deficiency anemia. What is the main differential diagnosis?
Manual worker hand, sir.
This,
Manual workers.
no, this is not. I'm very sorry. I have to disagree here. This is Kalonikia.
No, no,
And
differential diagnosis, sir. Differential.
right. Okay. Sorry. I got it. Yeah, that is fine. I accept that. So, what is the differential diagnosis of iron deficiency anemia?
Iron deficiency anemia, sir.
Yeah. So please write rather than talking because other people then get disturbed. So iron deficiency anemia, menorrhagia, right? Poor diet, GI bleed, dietary insufficiency, malignancy. What blood test will you do? What blood test are we doing? Ferritin, total iron binding capacity, and iron studies. Excellent. Four causes we have already discussed. So blood tests required are full blood count, microcytic hyperchromic anemia, iron studies, serum iron, ferritins, total iron, TIBC. Causes of iron deficiency anemia for my younger colleagues, students, menorrhagia, pregnancy, you lose blood or you're not eating enough. Lack of iron in diet, GI blood loss, malabsorption like celiac disease, post-gastrectomy, parasitic worms, very common, excuse me, in subcontinent. Right. Okay. So, can you please tell me what do these figures show? I will give you a gold medal if you get it right. Sumera. What is on the right? What is on the left? You're getting it right. I'm very impressed. Huria, what is on the right of your screen?
Me's, me's line.
What is the term used? Licunicia right and Calonicia left. Excellent, brilliant. Right. So remember ticks. Mnemonics help. Remember romance, I told you, and remember ticks. Iron deficiency anemia, common causes. When you're asked of microcytic anemia causes, thalassemia, iron deficiency, chronic disease, and sideroblastic anemia. That is your microcytic anemia. Microcytic anemia, you know what is microcytic anemia? When your red cell is smaller than the normal size. Okay, are we happy so far? Right, okay, moving on. Right, I am not reading question for you this time. You read it for me, please. All I need from you is the correct answer. I want you people to help me find the right answer. So, guys, someone said five, five, five. Most of the people are saying five. Actually, answer is four. This is ecclesia. Yes, most people now are coming with four. That is a correct answer. Dysphagia is at the higher level, at your throat level, at your mouth level, right? Ecclesia is your nerving of your lower esophagus. This is your. Can someone help me to understand these images, please? This is what is this and what is this? Korea, can you please help us? Can you help the gang? That what are we talking about? So that is how your ecclesia looks like. And this is your dilated esophagus here. And again, this is your dilated esophagus, right? That is how your ecclesia looks like. Right. Okay. Moving on to the next question. Right. What is the answer? Right hypochondrial discomfort. RHC means right hypochondrium discomfort and weight loss. Weight loss is always sinister. Think of a bad diagnosis. Razia, what is the answer? Hifsa, you're getting it right. I'm very pleased. Very good. Excellent. Alpha fetoprotein. Can someone tell me what is the description of this liver you can see? It is not enough for you to know what it is. What is required is that you need to be able to describe what you see. Nodular irregular border of liver, meaning that this is your hepatocellular carcinoma. Alpha fetoprotein is your tumor marker. Okay, how many tumor markers you are familiar with? Right, okay. These are your common tumor markers. If any disagreements, very happy to take your objection. These are common tumor markers, alpha fetoprotein going in up in liver, CEA, carcinoembryonic antigen in colorectal carcinoma, CA15-3 in breast carcinoma, and ovarian CA125, HCG in ovarian cancer, pancreatic tumor is your CA99, right? Agree with me? You all seem to be very quiet this time. Guys, agreed actually, right? At least one of you agrees. Okay, next question. Right, this is a difficult one. Please give me the correct answer. I'm saving my energy by not reading it. You do the work and I will help you with the answer. Brilliant. Everyone got it absolutely right. Looks like sometimes my questions are far too easy, perhaps. Right. Okay. Excellent. I'm very pleased. Actually, this is correct answer B. So anti-intrinsic factor antibodies, they bind to intrinsic factor made by trichal cells in the gastric fundus. Vitamin B12 is absorbed from the terminal ileum via intrinsic factor, right? Just a little reminder for you. Yes, Huria, this is pernicious anemia. You're right. Okay, next question. Right. Okay, please read. 23-year-old female presenting to A&D department with history of recurrent abdominal pain. Recurrent abdominal pain, 23, younger patient. So something chronic going on, predominantly in the right iliac fossa. There is a differential diagnosis of pathologies in the right iliac fossa. Razia, it cannot be cancer. She is 23.
Celiac disease.
We will find out. Celiac disease is not that common, is it? There are commoner things from that. She is sometimes tender across the entire abdominal region. You will not be tender in celiac disease. 4 week history of weight loss of approximately 10 kilogram alongside loose stools. Would you like to change your diagnosis now? Someone said IBD. Can you tell me, please, what IBD is? I hope it is not irritable bowel syndrome. Someone said Crohn's. Sajid, thank you. This 4 differential diagnosis, right? Let's see. These are your 4 differential diagnoses, right? Appendicitis, ectopic pregnancy. Well, that's very unlikely. I should have not written that. Crohn's disease, yes. Ulcerative colitis on top. Appendicitis, I don't agree with that either. Diagnosis is actually immediately obvious here. Outline 4 investigations. You will do pregnancy test, which you will do anyway. CT abdomen, that is the right diagnosis. Full blood count hemoglobin, someone said sigmoidoscopy, Sadia, that is correct. Abdominal X-ray, well, if you are doing CT abdomen, why would you want to do abdominal X-ray? Stool sample and sigmoidoscopy. Now let's see what her doctor is doing. Her doctor has asked for a colonoscopy. Well, excellent, that is fine. So the GP arranged a colonoscopy. What findings on colonoscopy would be supportive of a diagnosis of Crohn's disease? So her GP is thinking like we are thinking. So findings on colonoscopy are, this is the complete list. Yes, strictures, fistula, correct. Skip lesions, narrowing of lumen, cobblestone appearance, right? These are your features on colonoscopy, right? Okay, so remember this picture, please. Just a common reminder. Skip lesions, right? This lesion, this lesion, this lesion, this lesion. And this is your continuous chronic involvement in ulcerative colitis. And these are your skip lesion in Crohn's disease. That's the difference between Crohn's disease and ulcerative colitis.